salt headline, and we've seen things move back and forth. But we do know that excess sodium is responsible for hypertension, and that hypertension is a leading risk factor for heart attacks, strokes, and kidney failure. I'm Sandra Mullin. I'm the Senior Vice President for Vital Strategies, and the vision of my organization is that everyone deserves to be protected by a strong public health system. I had to get that out as a promotion for our organization. I'm pleased to be here today with this distinguished panel and to both introduce each speaker and to moderate it at the end. I'll ask each speaker to come up one at a time, and then at the end we'll have a discussion together. Each speaker will be going on for about 5 minutes and no more. Less is fine. And I will ask you, or Alexi will actually put a sign in front of you to tell you when there's a minute left in your presentation. So I'd like to begin by introducing our colleague from Denmark, Dr. Søren, who joined the Danish Health Authority in September 2011 as head of hospital services and emergency management. He oversees national planning of specialized hospital services, emergency services, preparedness, communicable diseases, immunization, and screening programs, as well as the national action plans in the fields of cancer, cardiovascular diseases, and mental health. I think they should pay you more. That's a lot of work. And one of the reasons we were very excited to have you here today is that, as many of you know, Denmark was a trailblazer in banning trans fats, or virtually banning trans fats, in 2003, and we'd love to hear from you. So welcome.
Thank you very much, Sandra, for inviting me here to share the Danish experience. And thank you to Sandra and to Tom for the great work you are doing with Vital Strategies and the Resolve initiative. I would also like to congratulate the WHO on launching the Replace initiative on trans fats. So what you're doing is extremely important, Sandra and Tom, and I'm basically here to promise you whatever support you want from us. And I'm going to begin by sharing our experience in Denmark. As you mentioned, we were indeed the first country in the world to impose a near ban on trans fat foods in oil, fats and oils. I'm going to explain a little bit about the background, why it happened that Denmark was the first country in the world to do so. Going back to the mid-90s, as you mentioned, Sandra, the evidence was emerging. Mid-90s, that trans fat was indeed very dangerous. We were, in our country, very early adopters of that emerging evidence, very much due to a couple of leading scientists and clinicians that saw that evidence. They had the evidence of their own, and they took it in and said, this is important, we have to act on this. We had, at the time, a board of independent scientists referring to the government on food and health. And this is the legislation that was passed in 2003 by our parliament with a broad majority, was an excellent example of evidence-driven legislation. It took some years for the evidence to mature and for the business case to mature and become a political necessity, but it was very much driven by scientists, by clinicians on the basis of the evidence. So that's one take-home message from the Danish experience. Look at the science, use the science, you have a very good business case. We managed to do that. We were not alone in doing that, of course. WHO was also a very early adopter of the evidence, highlighting in the early, around the turn of the century, that this was a necessity and that trans fats were indeed a heavy risk factor for cardiovascular disease. So we introduced it. The legislation that we introduced in 2003 was extremely simple, saying basically that the amount of industrially produced trans fat acids in oils and fats used in foodstuffs should not exceed 2 grams per 100 grams of fat. So that's the second take-home message. This was very, very simple, very easy legislation, focusing on ingredients and focusing on a measurable item. And of course, many have asked, why is sticking to 2 grams of 100 grams of fat? Why not 0? And I think there were, at the time, and perhaps still is, some technical reasons for why a total ban is not technically feasible. For all practical purposes, this has shown to be extremely effective in eliminating trans fats in our foodstuffs, and we chose that limit at the time because we knew that then the amount of trans fat in the final foodstuffs that is intaken would be below what is risky for your health. We have since been proven right, and we also have very convincing evidence indicating a substantial effect on premature mortality of cardiovascular disease in our country as a result of the introduction of our trans fat ban. This is, of course, not randomized evidence, and of course, there are always academic reservations you might make, but it is very, very convincing evidence. It is evidence to the fact that it indicates an estimation of 700 lives saved per year in our country from cardiovascular disease because of our trans fat ban in 2003. This is a small country population of 5.6 million, so 700 lives, an average of 2 lives per day, is indeed very, very significant. We also have similar epidemiological evidence from, I believe, New York, where there has also been introduced trans fat acid bans, and where you can compare across various populations. So during the last 15 years, we have regularly performed controls of the level of trans fatty acids in relevant foods. This is the third important take-home message from the Danish experience. Control your implementation. This has been done regularly, systematically, annually, with reports by our Government Agency of Foods and Veterinary Affairs using validated tools for measuring industrially produced trans fat in foods. The results of the regularly performed controls have showed an increasingly good compliance with our legislative measures. Basically, the non-compliant foodstuffs are more or less illegal imports that sort of are passing through the non-regulated barriers of importing foodstuffs. We have an immigrant population in some of the largest cities, especially in Copenhagen. They will introduce local varieties of foodstuffs through other channels, and this is where we see the largest non-compliance. We are very happy to see that other countries have followed and also setting legal limits, and we are very pleased to see that it's finally moving ahead inside the European Union, with the European Commission in 2015 pointing to a legal limit on industrially produced trans fatty acids as an effective measure of protecting consumers. And we expect a common European initiative to be tabled by the European Commission following an impact assessment. This would potentially broaden the scope to the whole European market inside the European Union. And this is extremely good news for us in Denmark, especially when you look in the history. In 2005, 6, 7, we did have some issues between Denmark and the European Commission where they thought that we were sort of limiting marketing mechanisms by our trans fatty bans. That was repealed, and we are very happy to see that the European Union is moving. Finally, and this is perhaps the fourth take-home message, is engage early with industry. We had a feeling when we introduced this in 2003-04 that it would not affect quality of foodstuffs, it would not affect availability of foodstuffs, and it would not affect prices of foodstuffs. And this has also proven to be the case. So there have been no examples of foodstuffs not being available to Danish consumers that they wanted, whether it be donuts or microwave popcorn or whatever, included a lot of trans fats. So alternatives were fairly easy to adopt also for industry. Prices has not been accepted, and industry with a slight initial hesitation has also been supportive. We had two large industries on margarine at the time. They were hesitating a little bit in the beginning, but they quickly picked it up also as a competitive issue, and they complied. They had to readjust their production lines in a sense, and they managed to produce and deliver margarine to Danish consumers without a price increase, nor with a decrease in quality of margarine. So with these words, I leave the Danish experience for your inspiration, and I'm happy to answer any questions.
Okay, thank you so much. Thanks very much. And we will hold questions until everybody's had a chance to speak. I have to say that until I started preparing for this panel, I hadn't actually thought about the Danish in the same way. And those of us who live in the United States know that it's a common breakfast item. But so we can both give you credit and blame for that. But now it's trans fat free. Thank you so much for those words. So the next speaker is from a Jamaican colleague with whom and with which we are working very closely with Jamaica on its sugary drinks work and on the Jamaica Moves campaign. And I'm delighted that Dr. Jacquiline Bisasor-McKenzie is here to speak. She's had 25 years of experience in healthcare systems, and notably, and this is, I'm sure, quite difficult, she's reduced waiting time and patient flow in emergency departments and increased capacity at health centers in Jamaica. She's the first emergency physician to be appointed as a consultant in the public sector, and for 10 years served as head of the Accident and Emergency Department at the Spanish Town Hospital. She's now the Principal Medical Officer and Director of Emergency Disaster Management and Special Services at the Jamaican Ministry of Health, and I welcome you to give some remarks. Thank you.
Hey, good afternoon, everyone. I want to say a special thank you to Vital Strategies, a really wonderful set of people that I'm just meeting recently, but it has been a wonderful experience so far with them. Ladies and gentlemen, I'm very happy to be here to share the Jamaican experience in terms of reducing our use of sugary beverages in our island. 78% of all deaths in Jamaica are caused by non-communicable diseases, and unhealthy eating is a major risk factor for NCDs. Jamaica's economy is projected to lose over 77.1 billion Jamaican dollars over the next 15 years in terms of direct and indirect costs due to cardiovascular disease and diabetic complications alone. The four major NCDs, cardiovascular disease, diabetes, chronic respiratory diseases, and cancers, account for 24% of premature deaths. That are deaths occurring between the ages of 30 to 70 years in 2015 in Jamaica. Research in the Caribbean has found that the consumption of sweetened beverages, limited fruit, vegetable, and water intake, and low physical activities is significantly associated with obesity. A recent national study reported in Jamaican adolescents 13 to 15 years old, 72.5% consume one or more soft drinks per day, and 27.5% 3 or more times per day, with 27.7% are physically inactive, and 53.4% spend 3 or more hours per day doing sitting activities. 22.1% eat fast food 3 or more days per week, and 14.1% did not eat any vegetables. And these are just the 13 to 15-year-olds. The health consequences are serious, and long-term effects which are physical and psychological. The projected impact on the GDP of non-communicable diseases and mental health is huge, equivalent to 18.5 times the level of health expenditure in 2013, and 106% of Jamaica's 2013 GDP. The economic impact on the GDP of diabetes and cardiovascular disease alone is $5.89 billion US. These are devastating consequences, and the government of Jamaica have committed to halt this epidemic. We have approved some key policies: a national strategic and action plan for the prevention and control of NCDs in Jamaica from 2013-2018, a national infant and young child feeding policy, a national food and nutrition security policy, a national operation action plan for the prevention and control of obesity in children and adolescents. Jamaica Moves is our flagship NCD reduction program, and it was launched in April 2017 with a focus on physical activity, healthy eating, and raising awareness about your health status. Jamaica Moves in School is a program that we are going to be launching in September this year in collaboration with the Ministry of Education, Youth and Information, who we're also developing with a school nutrition policy. We have also put together a national food industry task force, which is formed to address product reformulation, food labeling, food marketing, and advocacy and communication. The Caribbean Public Health Agency, in collaboration with our Ministry of Health, via North-South cooperation with the government of Japan, commenced in October 2017 implementation of a project to reduce salt consumption and to develop model salt reduction policies. But I'm really here to tell you about our National Obesity Prevention Project and campaign that has been funded by Bloomberg and has been implemented in collaboration with Heart Foundation and Vital Strategies. This Are You Drinking Yourself Sick campaign aims to warn the public about the amount of sugar present in sugary drinks like sodas and fruit juices and the health harms that is associated with consuming them. The campaign is centered on a 30-second public service announcement on national TV channels, in cinemas, on radio stations. In addition, campaign ads run in the newspapers and digital media. The media campaign has had a major impact on public opinion and has raised awareness of the threat that has been imposed by unhealthy consumption habits of the population. There have been several editorials that have resulted from this campaign. And an obesity prevention public opinion survey was conducted by the Heart Foundation of Jamaica and indicated that 64% of respondents supported a tax on sugary drinks. The study further stated that 9 in 10 Jamaicans agreed that it was important that the government be involved in helping to solve the problem of obesity. Now, while we are only still exploring the possibility of special consumption tax on sugar-sweetened beverages, there have already been significant impact on the industry players by this campaign so far. Soft drink manufacturers and other food industry players are doing reformulations already of their products to decrease sugar and caloric intake. As a matter of fact, there is an open war in trade as manufacturers are challenging each other now to who can lower the caloric content and the sugar content more. Now, there has been some pushback from industries, but clearly this campaign has opened the discussion very widely, and public opinion is towards cutting sugar content. Now, we have a lot to accomplish in Jamaica, but we are fully committed to the cause, and we are grateful for our national, regional, international partners who have provided support for this program of work. And especially we want to thank Vital Strategies for the technical assistance that is provided for supporting the obesity prevention efforts, not only in Jamaica, but also in other countries like Brazil, Colombia, Mexico, and South Africa. Thank you.
I promise we didn't ask her to thank us at all, so we just want to make that clear. I will say I was in Jamaica for about a month ago, and I must have asked at least 50 people whether they had seen or heard the Are You Drinking Yourself Sick campaign, and as an important measure of a campaign success is whether anybody saw it or heard it. I'd have to say 49 out of the 50 people had heard it or seen it, and the one person who hadn't seen it or heard it said a friend told him about it, which is even better, because the talk value of a campaign is... Anyway, thank you so much, Dr. Bisasor-McKenzie. The next speaker is Dr. Tom Frieden. He was health commissioner under Mayor Mike Bloomberg, leading efforts to reduce smoking and other leading causes of death that increased life expectancy by 3 years. When he was health commissioner, the first trans fat ban in fast food restaurants occurred in 2007, and as you know, in the United States, a virtual trans fat ban is going into effect this year. He was director of the Center for Disease Control and Prevention under President Obama, and now and oversaw the work that helped end the Ebola epidemic. He now leads Resolve to Save Lives, a $225 million 5-year initiative housed at our organization, which aims to save millions of lives from cardiovascular disease and to make the world safer from epidemics. And I'm sure he's going to tell us all about his Replace initiative. So welcome, Dr. Frieden.
Thanks very much, Sandy, and really thank you for both of the prior speakers for very inspiring progress. Denmark showing the way and showing that you can have great food and it doesn't have to kill you. And Jamaica showing how important it is to really promote awareness and policy change, that these are two sides of the same equation. We're looking at Resolve to Save Lives, an initiative of Vital Strategies, specifically at cardiovascular disease. I gave a talk this morning and someone after it said, you know, you didn't talk about tobacco or sugar. And they were right, and I should have. So I'm going to correct that by saying right now, tobacco remains the #1 cause of death globally, and much more needs to be done, but there's been progress. And there's been progress by focusing on specific interventions that can be scaled and getting civil society to push hard for effective programs, and Paula can talk more about that. I'll talk about sugar in this conversation. At Resolve to Save Lives, we have a simple equation. When does 50 plus 30 plus 0 equal 100? If we can increase the proportion of people around the world whose blood pressure is controlled from the current abysmally low rate of 14% to 50%, reduce sodium consumption by 30%, and get to 0 grams of artificial trans fat, the world can save 100 million lives over about 30 years. These are really important high-impact programs. Cardiovascular disease kills 18 million people a year around the world. And it's clear, let's take them one at a time, trans fat, sodium, and sugar. Trans fat is an artificial product added to foods that kills people. And as Denmark showed, it can be replaced without changing the taste, cost, or availability of great food. Only your heart will know the difference. The World Health Organization has now called for global elimination, the first elimination program in a cardiovascular disease risk factor. We know about polio and smallpox and guinea worm and river blindness. These are all really important programs. First time we're applying this concept. And as Dr. Tedros said, this is a flagship for WHO. It's in the global program of work, trans fat free by 2023. And imagine after that date, no child born anywhere in the world will ever have any risk of exposure to artificial trans fat. That's a wonderful and mobilizing possibility. And WHO has released this replace package. It's a very specific technical approach and political approach to how to get to 0 grams of trans fat. And countries around the world now have a way forward to do that. I won't repeat Søren's great points because they really are the pathfinder in this. But the bottom line here is that if the world does what WHO has called for and eliminates artificial trans fat, then over the following 25 years, there will be 17 million fewer deaths from heart disease. So a lot is at stake, and I believe it is the case that the days of industrially manufactured trans fat are numbered. So we have a big success, and we need successes in the non-communicable disease space, because one of the reasons for slow progress is the sense that these are chronic diseases that we can't do much about. As the tobacco control work of Paula and others shows, it's possible to make really big progress if we focus and if we implement effective programs. Now, sodium. Hypertension kills more people than all infectious diseases combined, more than 10 million people a year. And we consume way too much sodium. Interestingly, an international collaborative study done decades ago measured sodium intake in dozens of populations in dozens of countries. And there was a fascinating hint from 4 populations that were in pre-industrial societies. In each of these 4 populations, the amount of sodium consumed was about 500 milligrams. That is really about a tenth what most people consume. And there was no low sodium problems. There was no people fainting. But what you found was that there was also no age-related increase in blood pressure. So one of the reasons that in the US, for example, 70% of people over the age of 65 have hypertension is that we're all consuming vastly too much sodium. To reduce sodium, we need to do 3 things. 1, work with industry to get them to reduce levels. 2, work with those who prepare food to reduce the added sodium. And 3, think about alternative products, some low sodium salts that may have a role. Last and not least, sugar and soda. In the US at least, the data shows that the leading driver of obesity, the single leading driver over the last couple of decades, appears to be the increasing consumption of sugar-sweetened beverages. If you just look at calories in, calories out, the biggest change is an increase in calories in, and about half of all of that increase is from the increase in sugar-sweetened beverages. So in 2009, Kelly Brownell and I and others have called for a penny an ounce tax on sugar-sweetened beverages. The soda industry wrote in their newsletter that this was the greatest threat that they had ever faced. So that told us we were on the right track. Mexico, a 10% tax resulted in a 12% reduction in consumption, 17% in low-income areas. In Berkeley, California, a penny an ounce resulted in a 21% decrease, especially in low-income areas. It's feasible but politically difficult. And I'll end on this point. For all of the non-communicable disease work, now Sandy remembers this, I got into trouble because in one of the first interviews I gave when I was named health commissioner, I said that for many years my enemy had been a microbe, a germ, Mycobacterium tuberculosis, but now it was a really low-life form, the tobacco executives. And I got a letter on Philip Morris stationery saying essentially that that was a form of hate speech, that no individual is less than human. And so the next time I gave a speech, I said those two things, and I said they're absolutely correct. And from now on, I'll use completely dispassionate language and just describe tobacco executives as mass murderers. I didn't get any more letters from Philip Morris. But sugar, the food industry is different. Unlike tobacco, we do need food, and they have a big impact. So we have to work with them. And as Søren said, you can do that constructively. We want them, for example, when they replace trans fat, to use the healthiest oils possible in doing that. And that means giving them time and helping them to make the transition. But we can't lose sight of the fact that there is a proven history that the tobacco, alcohol, and food industries have infiltrated public health organizations, subverted science, and blocked public health programs that would protect health. So yes, we do need to collaborate and coordinate where appropriate, transparently, and through a third-party intermediary, but we should do that eyes wide open. Thank you very much.
I was Tom's public relations director at the time, and as you can tell,
You stole the time.
and he was both a dream and a nightmare. And you can see how unable he was to be outspoken. Anyway, thank you very much, Tom. And the next speaker is someone who's also quite outspoken, Paula Johns. And Paula is the General Director of ACT Health Promotion. She is a sociologist with a degree in international development from the University of Roskilde in Denmark. Luckily for you, we didn't conduct this panel in Danish, though we almost could have. We could have, 2 out of the 5 speakers. Paula has been a part of the negotiation meetings of the Framework Convention on Tobacco Control, which Tom alluded to her great history in doing tobacco control advocacy work, and has been working on tobacco control with it and its protocol since 2001. She has also, for over 20 years, been coordinating projects promoting human rights, gender equality, environmental preservation, and public health. She's a member of various councils and on the steering committee of the Alliance for Adequate and Healthy Diet. And we'd love to talk about your experience in Brazil and any other words of wisdom you'd like to impart. Thank you.
Hello. Well, first of all, thank you for the organizers to giving room for the advocate's voice here, and outspoken, as Sandra has, and many of you know it already. Well, first of all, I think I would like to first just ask a question for the audience and for us to think through. What is food? And having asked that question, then I want to start by stepping on Tom's last conversation about what are we talking about when you talk about partnerships with the food industry. My understanding of food is different than what the major corporations of ultra-processed foods are selling out there. Coca-Cola sodas are not food, and many of these ultra-processed cookies are not real food. We have so much of like either empty calories or full of trans fat things that are eatable, but they are not nourishing. They are not food. That's not what really feeds us. So I think it's good to put in perspective when we talk about partnership. And from my perspective, I'm very critical of these public-private partnerships within the NCD scope. And the reason for that is that, for me, an effective public-private partnership would happen first through regulation and taxation. And they ask for the industry if they want to be a partner. And a part of that solution is that they don't fight back effective policies. Because as an advocate, what I see every day of my life, working through the Brazilian legislative and the executive power and all the powers, is that the major obstacle we have for implemented public policies which are effective, it's the industry lobby. So it's from that perspective that I have really restrictions about how do we work together. And I'm talking from the perspective of civil society, not of governments. Of course, governments should talk with the industry, but I think we need to be very clear about our roles depending on where we stand. And as a civil society advocate, I think civil society needs to be really strong on that issue, or else we'll never move forward with effective populational measures. We know that. We have learned the lessons from tobacco, what works. There are 4 major areas. Fiscal policies, which are the obvious ones, which would help us to promote good and small business that produce real food to survive, because as it is of today, it's almost impossible to survive as a small business producing real food. So we should at one end like promote that, and we need to tax to try to level the playing field, which is not level at all today. So that's one of the areas. The other area, it's labeling. Most of these ultra-processed foods in the market, first, they have lots of false health claims on the front of the package. So there's gluten-free, lots of fibers, vitamins, and this and that, in foods which are not really full of the things that they claim they have inside. And with all the bad things that they have, they are hidden, and you cannot interpret it. Not even if you are a PhD nutritionist can you interpret those labelings. I can't read them myself if I don't have really, like, what do you call it, a lupa, like these really powerful glasses to be able to read it in the first place. And even when I can read it, I cannot understand it. And I guess this is true for the majority of the population. So we really need to have really clear front of package labeling that warns about the bad nutrients in those foods. We need that as a policy linked with the marketing for children, because it's not fair that we blame the parents when you have to fight with totally unethical marketing practices targeting our kids with the most unhealthy foods that exist. Not foods, right? The most unhealthy eatable products that are there in the market that we call them food. We should perhaps start by stop calling it food, because it's not real food. So that's another area. And the 4th area, because my time is about to be over, it's about like the environment. So like we should really protect children in the school environment. We should really have like only real food in the school environment. And last but not least, even like I don't like the calorie count thing. I think it's more than that, and it's more complex than that, because empty calories are different than real calories, which are good for you. So that's another thing. We should drink water, to be honest, and why not? I mean, we can really learn to drink water instead of drink very heavily sugary stuff. And also I would say that it's not even, and I mean, we are way behind the food policy issues. But to be honest, it won't be enough just to cut the sugar and substitute it by artificial sweeteners, particularly in products that are targeting children. We need to think about that area too, because artificial sweeteners are not the immediate solution, just as a note of caution for ourselves. Thank you.
Thank you so much. Thanks, Paula. So our last speaker, and thank you all for being quite on time. We really want to leave some time for discussion. Is last but not least, I should say, is Dr. Nandita Murukutla. She's a behavioral scientist at Vital Strategies and the VP of Global Policy and Research in the Policy Advocacy and Communication Division, working in tobacco control, obesity prevention, road safety, and emerging priorities for our organizations such as urban and environmental health. And she also oversees our communication programs in India. So welcome.
Thank you and good afternoon. So the speakers before me already described the burden of diet-related illnesses, and others have spoken of industry interference and practices that really promote these unhealthy commodities. So I won't belabor that, except to say, on your way out, do please look at our report, Fool Me Twice, that describes some of these interference and practices in good food policy. The focus of my presentation today will really be on the use of communication and as it applies to food policy and food behaviors. And in my brief presentation, I'll hope to leave you with two messages. One, the importance of a more macro view of communication, a broader definition of communication. And two, an understanding of some of the behavioral science principles underlying these communication strategies that can both promote unhealthy commodities, but can also be used by us to promote healthy choices and diets. So let me start with the first. In public health, we've accepted this ecological view of health. We accept the influence of environments, built environments, and extraneous factors on our behaviors and ultimately our outcomes. Communication likewise requires this broader definition. We understand communication to be direct advertising, and no doubt that's important. This is why any regulation that touches upon advertising by soda, tobacco, alcohol, it's hard fought. We know it influences behavior, we know it influences policy. But there are many other ways in which communication influences our behavior, and this is what I really want to drive home. So consider, for instance, for a minute, all those behaviors and those products that you see in television content, in films. Consider the packages in which food or drinks are sold to us, the size, the design, the layout, and the claims on those packages. And consider where these products are placed. Are they in dark, dingy corners of stores, or are they at eye view level, particularly the eye view level of children, where they can be touched and seen and grabbed? All of these really describe key marketing principles that are derived from behavioral economics and marketing strategies that are intended to promote their use. So no doubt, decades of evidence, whether it's in tobacco control or now in food policy, we know that all of this drives consumption of unhealthy foods. So what do we do about it? Well, we can use the very same principles, turn it on its head, and use it to promote healthy choices. And here are the ways in which we can do it. So first of all, marketing. Marketing and the promotion of these products, what it does, especially when you pair a product with a glamorized character, is it suggests that this is desirable and this is what you should do. So marketing restrictions de-glamorize these products, whether it's tobacco or an athlete that consumes a sugary beverage. Consider, again, labeling. So front-of-pack labeling, interpretive front-of-pack labeling that warns consumers about high quantities of unhealthy ingredients helps them make quick decisions. We know from research that people make a decision in about 6 seconds. So in those 6 seconds, what are they going to choose? That's what interpretive front-of-pack labeling can do. And finally, restrict access in terms of point-of-sale purchases or where products are placed in stores or where they're sold around schools, in cafeterias, so that they seem less ubiquitous, less socially acceptable and normative. And I'll conclude again, I know my time's up, with direct advertising. So the same forms of advertising that's used to promote a product to make known the unhealthy consequences of consuming those products. And we know this now from experience such as the one in Jamaica, where these communication campaigns internalize for people their own personal vulnerability to those products and the diseases that they will face. And this has two functions. One, it changes their own behaviors in their homes, in their families. But two, it creates the kind of supportive environment we need for policymakers that want to implement strong protective measures. When people know the harms that they face, they will support such policies, and that is really the goal here. So in conclusion, a macro view of communication that thinks of communication in its broadest sense, and the use of communication to really address this asymmetry that's otherwise existing in our markets. So thank you.
Thank you so much, Nandita. So I'm going to kick off a bit of a discussion. We've got about 20 minutes, and then I'm going to turn it over to all of you. So if you're thinking about questions, get ready to ask them. But let me actually first turn to you, Tom Frieden. You've had both the local experience in New York City of getting some very, at the time, legislation, first of its kind legislation through, or using the health code to do so. What would your advice to be to countries about how do you get started? You've obviously done a great deal.
I think what Paula said is really important. You have to get involvement of civil society. Government isn't generally going to do the right thing unless it's pushed to do the right thing. And in the NCDs, we don't have a lot of natural advocates. The people whose lives we save don't know we saved their lives, and the people whose lives we failed to save aren't around to help. So that means you need to be strategic and identify what I think of as winnable battles. That is, the things that aren't going to happen anyway, no reason getting on a bandwagon of something that's inevitably happening, and they aren't tilting at windmills, but they aren't definitely going to succeed. You try it, you try to succeed. If you fail, you'll come back again maybe a year or two later. So one is to identify areas where you can make progress. That's why we think global elimination of artificial trans fat is a win. When we proposed this in New York City, we also proposed menu labeling. The industry sued us over menu labeling, but on trans fat, they just said, please don't tell anyone, we're taking it out of our food, and if you tell people, they think it tastes worse, but it tastes the same, we've checked. Because they really didn't want to have to go to the court of public opinion and explain why they were suing us for the right to continue to poison people with a product that nobody knew was in their food in the first place. So I think choose battles that you can win is one. And the second is keep your powder dry, because there will come a time when something becomes possible. I think of Mexico City with smoke-free legislation. There was a quick decision made to go smoke-free. You had a very dynamic health minister of Mexico City. The initial regulation was not good. It said 25% of the space could be for smokers. He said, oh, people are just going to sue and fight over that. No, everything has to be smoke-free. We're doing it next month. And he did it. And he implemented well. So you have to have the technical, the operation, the political preparation so that when an opportunity arises, you can move quickly and take advantage of it.
Sorry. Can you also talk about how you were able to engage the finance part of government in Denmark, the Ministry of Finance or other players within government to take on board what the Ministry of Health's proposal was going to be, given the data that you had to embolden you? How do you navigate that?
I think that, as I was trying to highlight in my introduction, I think one of the key take-home messages was that industry was engaged in a dialogue, in a constructive dialogue, very early. Food and agriculture is very big in my country. Denmark is a rich country, and we basically became rich from agriculture and exporting bacon to the British breakfast table. And that is still number 2 export, where it's now been superseded by pharmaceuticals. So food and agriculture is big in our country. But we need to engage in a dialogue with them, and that was one of the key successes. Back then, there were margarine was still also big, and there were 2 margarine producers in the country. They were back then, I think at least one of them, I believe 2 of them, were still back then family-owned. So that made the dialogue somewhat easier. I believe they have now been bought by multinationals. So that was more or less along the lines as what Tom was saying, that they didn't want to look the consumer in the eye and say, we are poisoning you. And then it became also a competitive edge between them to sort of engage in delivering the first trans fat-free margarine for the Danish consumers. And also the fact that they had to adjust their production lines to produce trans fat-free margarine. That cost them some money because you cannot use the same production line. So there was issued at sort of time-limited derogation for the margarine producers to make it possible for them, while at the same time appealing to their business sense. A bad business person will blame everybody else for why they cannot make a profit. A good business person will see the challenge of delivering the same but better product for the consumer at the same price and still making a profit. And I think as I learned this history, I was not part of it directly back then. This is sort of one of the reasons for the success that happened. And then that they felt confident, and we were quickly able to show that foodstuff availability and taste and foodstuff quality and price was not affected. So that was sort of the sense. Of course, I mean, our society is heavily regulated to begin with, including our food and agriculture business. So they probably weren't that hesitant towards regulation as you will see in other societies.
Actually, if you don't mind, I'd like to ask Søren a question as well, because you mentioned in your remarks that the European Commission might take action. And as we go toward a global elimination campaign, we're looking for blocks. At least 2 WHO regions are vying to be the first to become trans fat free, so that's encouraging. But the EC, I know, has taken this up. Are there things that civil society can do or that people can do to encourage their own governments, if they're in Europe, to take action there?
Certainly. I mean, as any student of the European Union and the EU Commission and the governance around that will know, it's not a rapid-moving machinery, European politics. But it's moving slowly along. I think what you need to create a momentum, of course, certainly in civil society, but I look at the European Union, there are already several other countries that have introduced, are introducing, and as soon as there will be a critical mass of member states in the European Union, I think it can move along. The European Union, as you should realize, is all about market access, free market access. So it's the same foodstuffs. And I think when a number of states in the European Union are ready, then the European Union should move ahead. But you should realize that the European Commission actually sued Denmark for introducing the ban in 2005 because of the argument that it was limiting marketing access, but they lost it because of the public health issue.
Thanks for that. And let me just quickly follow up by asking Paula about engaging civil society. I think it's recognized on this panel and in this room how important it is, but what is your advice on how you would engage civil society to think about this as a nutrition issue or a human rights issue or an equity issue?
I'll just make a quick comment on Denmark. I think one thing that helps, having lived in Denmark for 10 years, I think it's somehow a democracy that it's more protected from corporate interests than other places in the world. I think that helps a lot, that you can really act based on evidence. I think that what stops us from acting from evidence in some other settings in the world. I really love Denmark. I mean, just like with like being like giving this, I mean, it is more democratic in my opinion. In terms of mobilizing, I think of course, it's not an easy issue, and it's the daily challenge that we have, but I think one of the things that have helped a lot for tobacco, and I think it's very helpful also in this area, it's to expose the incoherence between like what the industry claims that they are doing to support us in the policy process and so on, that they want to be a part of the solution, and what they are actually doing. Of course, in tobacco, it was very powerful when you had the secret documents there from the industry that we could clearly see that they were lying. And I think we need to go through a similar path, and many of the people who are down in the field, they know that what the claims do not match with the practices. And I think the only way that we can make people angry about it is that showing that they are not practicing what they preach, basically. And I think our role is very much to, besides pushing governments, it's also exposing that for the population.
I'm going to turn it over to all of you. So if anybody has a question, please raise your hand. But I'm actually going to call out one person sitting in the audience today who we're delighted to have join us, and he's the Deputy General Director from South Africa, who, as you know, South Africa passed a sugary drinks tax, 10% sugary drinks tax last year in December, right before the end of the calendar year, and it just went into effect, so we don't have data yet, but we definitely saw a tremendous increase in public support through a lot of the work that was done there. Would you like to say a few words about what?
Yeah, I think it was a real challenge to get the sugary tax through. industry, as usual, lobbied quite hard, particularly in a country like South Africa, which is a developing country, so unemployment is high. And so the industry used the weakest point and said, well, what's going to happen is that people are going to lose their jobs, and there'll be high unemployment, etc. And so there was a huge hearing in Parliament, and but at the end of it, I think the parliamentarians were committed. But I think it's also important that you have strong political support. I think if your Minister of Health is marginal, if I can put it that way, and would not want to cause any controversy, you're less likely to want to be able to get these things through. So I think timing is critical. Maybe I should also share some experiences of some of our health insurers around sugary drinks and other unhealthy foods. So some of our insurers have attached an incentive scheme to healthy foods. So when you go to the supermarket, you are given a card where when you purchase these healthy foods, you get points for them. And you redeem these points in the usual way that you redeem such reward practices. And they've been reporting very positive behaviors through this point system. So that may be something we may want to think about in terms of sugary drinks and the like. The one question I had, though, was what about the disincentives? So some have asked the question, if the public health system says to patients, you should not be consuming sugary drinks, you should not be eating fatty foods, you should not be consuming alcohol and tobacco in excessive amounts, etc. And if you continue to do so, and you then rely on the public health system for the consequences of that lifestyle, should the public health system be financing the interventions despite the fact that you've been warned that you should not be doing so? And so I'd be interested to hear how countries have, if they've ever dealt with that, because some people have said that to us. They've said to us, why is it that you've put out these lifestyles and you've informed people, and people chose not to do it because they call us and we want to run a nanny state, as they say in South Africa. And so if you do that, then you're on your own, I would think. And so it'll be interesting to hear your views.
Can I ask Nandita to start with the response to that question as the behavioral scientist, communication scientist?
Well, thank you for that question. I think it is an important question and one that does recur frequently. I'll just respond to it by saying that if we consider our environments, they aren't a level playing field. So in fact, those that are most burdened are the ones that also don't have access to good food. So they live in food deserts. Those that are most vulnerable are the ones that are marketed towards. So what has a veneer of choice, in fact, isn't always a choice, and most frequently is a result of the lack of alternatives. So this is really essentially shifting blame, and a tactic that we have found that industry uses over and over, whether it's the tobacco industry, the alcohol industry, or now the sugary drinks industry, to pass the blame and the buck on to the consumer that's essentially a victim of circumstance. So I would urge that we not allow that argument and in fact enforce these correctives to create a level playing field.
I agree with everything Nandita says. I'll just take the data from the US, which I know best. If you go with the flow in the US, you end up overweight or obese, as 65 or 70% of people are in the US now. That's not because we became more gluttonous or our genes changed. It's because the environment changed, and the environment changed in ways that were commercially driven. Unfortunately, on the obesity front, there aren't a lot of long-term success stories in terms of reversing it. So if you then penalize someone for something that unfortunately, you're taking the person at greatest risk of health complications and making it harder for them to get preventive activities. Similarly, for tobacco, at least in many countries, most people started smoking as kids because they were addicted by the tobacco industry, and it's hard to quit. I would say that it gets a little more complicated when you're talking about employers. There are some employers who say, we're going to require you not to lose weight, but at least to participate in a program for your own health, so our costs will come down and you'll become more productive. That may be more defensible. There are others that say, we're going to help you quit, but you have to quit smoking, we don't hire smokers. That gets a little bit far afield, but if it's a private industry, you wonder. I don't know if that's ethical or not. It's kind of difficult. But anything we do has to have in it a route for the person to become healthier that's cost-free to them. But I think the bigger point is the victim blaming issue. And one of the other reasons for slow progress in the NCDs, I think, is that at some level we think it's people's fault. And we used to think that about infectious diseases. We used to think that, if you got a typhoid, it was a reflection of moral turpitude. And this was something that led to a lack of collective action to reduce risks. And so I think it's important, without absolving individuals from responsibility. I don't think we can say, oh, you're overweight because of society, so just sit there and eat potato chips and watch the TV. No, I mean, I think everyone's got a responsibility, but we have to accept that we are not as much creatures of free choice as we would like to think. And this is one of the main myths that we had to counteract in tobacco. Oh, it's a free choice to smoke. Well, it's actually not, because you started as a kid before your brain was fully developed, and nicotine changed the way your brain was wired, and the tobacco industry maximized tobacco to keep you addicted. So I think we have to, while not absolving individuals from responsibility, recognize our collective responsibility to make the default choice the healthy choice.
No, I agree very much. I just have another suggestion for an industry that you might want to consider engaging more, apart from big food, and that is retail. We are certainly in our country seeing, we're still waiting for the political momentum to move on tobacco regulation. Nationally, in our parliament, there's not a majority for doing more on tobacco regulation. It will eventually come, I'm sure. But we see some of the large retail chains moving voluntarily in removing tobacco products from the stores, or introducing voluntary age limit enforcements, etc., etc. That can be very powerful. Probably goes best for middle or high income countries. One thing big food respects, perhaps even more than the consumer, is the retail chains, because they have a lot of buying power to big food, and they will control what is in the stores, what is not, where it is placed, how consumer behavior is affected. And of course, there might be some bad dynamics between retail and big food that can be difficult. But if you engage one or two retail chains, you can actually create a good momentum that will change. So that's just another, and we're trying to do that in some areas in my country.
Okay, thank you, Dr. Søren. A quick comment from Dr. Bisasor-McKenzie, and then I see one hand for a question out there.
Right.
We may just have one question.
Yes. I think this is why it is important that we aim our programs at prevention. When we need to move our programs out of the hospital, targeting the people that are sick, into the public sphere to say, don't get sick. And I think it's so important for us to start in schools, for the children to become aware of what is healthy, because the children go home and they tell their parents, I don't want that. You try to convince your child to drink something when teacher says don't drink it, and that's a battle that you can't win. So it's so important that all our awareness programs are really aimed at preventing, letting persons appreciate what is healthy, what is going to work out for them in the long run, rather than trying to get them when they're sick already. It's going to reach everybody. But if you're moving out into the public space, that is where it is. Make them be aware of what is healthy and try to prevent the problems.
Okay, I think you had a question?
Yes, I'm just going to stand up. I hear a lot of responsibility on civil society, the governments, and the industry. But I was actually going to question Dr. Tom, if you are working with organizations that young people especially look up to, athletes and sports events, major sports events, where you have, for example, at the Olympics in Beijing, you had McDonald's sponsoring the entire Olympics. You have the Super Bowl where you have all the sugary drinks. Do you try to work with these major sports events to try not to, for example, with the retail business strategy, to see if they will not buy the sponsorship and try to work in that level? Or
I think Nandita and Paula may know this better than I. It took decades to get professional baseball not to allow tobacco chewing Major, major, major effort. Took a long, long time. So there are some partnerships that can work pretty well, or aligned interests, even if I don't call them partnerships. Walmart in the U.S., which provides about 1/5 of the food in the U.S., committed to reduce sodium by 25% and eliminate trans fat before it was required, and they did. So the retailers have a separate set of interests from the manufacturers, and that can sometimes be useful. Look at smoking in movies. This has been a big effort. India has done work on this. Other countries have tried. The U.S. has tried. But it's something that civil society, I think, really needs to push. But I think, again, both Nandita and Paula will know this issue better than I.
I'll be quick. I think it's a fundamental question that gets at whether or not our public figures want to be seen hand in glove with some of these companies. And that's essentially the challenge for all of us as civil societies, to denormalize these industries and these practices, such that, was it in the case of China, I think recently, where the Chinese premier refused to stand by a tobacco company? I think there was some instance of that recently in politics. That's what we're striving to do as civil society.
Okay, I'm afraid we're at 2 o'clock, and I know that there are a few other questions, but I promise to end it on time. Maybe you can catch people that you might have a question of on their way out. But I just want to thank everybody for being in this room for this discussion, and thanks very much to all of our panelists. Thank you so much.
Come through some